to the Chronic Chronicles. I'm your host, Lexi Halloran, and today we have another solo episode. If this is your first time joining us on the Chronic Chronicles, hi, welcome to the podcast. I'm so happy that you're here. I am Lexi. I'm 28. I have endometriosis, PCOS, POTS, factor V Leiden, ADHD, OCD, and probably other things that I'm forgetting slash missing. If you were to ask me though, I would say that my main chronic illness is endometriosis, and endometriosis is the whole reason that I started this podcast. So we are talking about endometriosis today. I do want to say though, if this is your first episode and you don't have endo and you don't want to learn about it, one, you should stay and learn about it. Hi, stay, please, please, please. Two, there are over 60 episodes. I think we're probably close to 70 episodes now, and not every episode is about endometriosis. We are called the Chronic Chronicles, so there are a vast amount of chronic illnesses that we have talked about on the show. So go backwards and listen, take a look if you don't feel like endo connects with you. But that being said, I really do think you should stay because we're going to talk about something that is really interesting today. We're talking about why endometriosis excision surgery is not covered through insurance most of the time, actually pretty much ever, unless they code it as something else. But not only are we talking about endometriosis excision surgery, but we are getting into the nitty-gritty details of insurance, CPT codes, and how these things are created, which you might have heard those last couple of words and been like, oh, girl, I don't want to listen to this. This is going to be so boring. And I get that. It's not boring, for one. And for two, you really should stay and learn about this because it is, one, interesting, and two, infuriating that this is how this works. But you should stay and listen, especially if, I mean, this is especially relevant to people that live in the United States of America because this is related, like this is American insurance, but it would also probably be really interesting if you don't live in the USA and you live in a different country like Australia, the UK, Canada, somewhere that has like universal health care, just to kind of learn about like what we go through here in the States. I'm not gonna like sit here and act like I know everything about insurance because I definitely don't, but I did have to learn heavily about insurance relating to endometriosis excision and how insurance works when you are chronically ill because it directly obviously impacts my life, but I want to teach you guys about it today. I do want to preface that in no way am I an expert on this situation. This is my own personal research. I did research it pretty heavily, so I'm pretty sure it's all correct, but please let me know in the comments if I say something that is not correct, and please correct me. Yeah, so this is just supposed to be like a little learning experience and something to open your eyes a little bit and encourage you to really hop in and do some research for yourself. So I'm going to get right into the nitty-gritty today of the episode. We're not going to do a catch-up because last week or a couple of weeks ago, I did a pretty hefty catch-up with you guys, and that was a pretty chill episode. So we're just going to jump right in to the ep. Like I said, today's topic is why endometriosis excision isn't covered. And I really wish that I had understood this years ago. I think that many of us try really hard to advocate for ourselves and ask for the right surgery, fight our insurance plan, and we still end up really confused, overwhelmed, and financially drowning. Like endometriosis surgery can be a very financially tough situation to be in, which is really disappointing because endometriosis excision surgery is okay, how many times have I said that already this episode? I'm so sorry, guys. But it's the gold standard of treatment and the very real, very heartbreaking truth about why it's so hard to access and why it's so hard to access, why it's so expensive, why insurance companies deny it, and why we still, in the year of 2025, almost 2026, we don't even have a proper code for insurance companies to use for excision surgery. So we're going to break down how we got here, why this matters, how it affects patients every single day, and what advocacy organizations like Endo Excision for All are doing to bridge the gap while we fight for systemic change. So grab your coffee, your heating pad, your electrolytes, whatever you need. This is going to be a really validating, eye-opening, and honestly empowering deep dive into excision surgery, insurance, CPT codes, and all of the nuance behind this. Okay, before we get into insurance codes and policies, we need to make sure we're all on the same page about why excision surgery is such a big deal. So, excision surgery is not just a more advanced laparoscopy. It's not just a more intensive version of the ablation. Excision is a technique, it's a skill. It's where the surgeon actually cuts out the endometriosis lesions from the root, not just the top, not the visible surface, but the full lesion, the entire depth. Think of ablation as kind of like singeing or quite literally burning off the top of a weed. It might look like it's gone, but the root is absolutely still there. And you can think of excision as digging that weed out, the root, the stem, everything, so it doesn't grow back, or at least that's the hope. Okay, so why does this matter? Because the data is very clear. Excision has a lower recurrence rate, but unfortunately, endometriosis has the tendency of reoccurring in most people. So, excision is the gold standard for treatment, but it is absolutely 100% not a cure for endometriosis. We still, unfortunately, almost 2026, do not have even an inkling of a cure for endo. But excision is still the gold standard. It has far better, far lower reoccurrence rates than ablation. Excision is more effective for pain, it improves fertility outcomes, and excision surgery identifies deep disease. It identifies deep disease that ablation misses. And most importantly, excision treats the disease, not just the symptoms. And here's the thing. Excision is not simple. It's something that most general OBGYNs are not trained in. True excision, especially for deep infiltrating endometriosis, can involve the bowel, the bladder, the uterus, the pelvic nerves, and sometimes even the diaphragm. So these are really complex, multi-organ, multi-specialty surgeries that genuinely resemble oncology or even advanced pelvic surgery. So when we talk about why excision surgery is so hard to get, this is why. It requires more skill, more time, more training, and far, far, far more resources. But if it's the gold standard, why isn't it accessible? And that brings us to my next point. To understand why there's no proper insurance code for excision, we have to talk a little bit about the history of endo. And honestly, the medical bias baked into that history. So, for decades, endometriosis was not taken seriously. It was considered a women's problem, a menstrual issue, something emotional, something exaggerated. It was, I honestly, women's hysteria just in a new decade. Patients were dismissed, gaslit, pain was brushed off. Women were told that they had a low pain tolerance, even though we quite literally give birth, but whatever. And for a long time, doctors believed that endo was just a bad period. Pregnancy or a hysterectomy cured it. Newsflash, they do not. It didn't involve organs like the bowel or the bladder. Hormones were the answer. So they put us on things like birth control or Lissa, a whole bunch of hormone cocktails. And that ablation was good enough. This mindset really shaped everything that came next, including how the procedure was coded and reimbursed. When the original laparoscopy codes were developed decades ago, the medical system simply didn't recognize excision as its own complex procedure. Ablation was the norm. Ablation was the majority of surgeries that were given for endometriosis. It was the only way that patients were diagnosed with endometriosis was through an ablation laparoscopic surgery. And excision just was not widely taught. And endometriosis was not treated as a serious disease. It was just treated as a bad period. A CPT code, which stands for the Current Procedural Terminology, is a standardized medical billing code used in the United States. Every time a provider performs a service or a procedure, from a simple office visit to a complex surgery, it has to be assigned a CPT code so that insurance knows what was done, how complex it was, and how the insurance company should pay the provider. So you can think of a CPT code as the language that doctors and insurance companies use to communicate. If it doesn't have a code, insurance can't properly recognize it or reimburse it. So when the AMA, the American Medical Association, created CPT code 58662, which is still used today, they lumped ablation and excision together under the same code. That being said, a 5-minute ablation and a 5-hour excision were treated and are treated as identical procedures under the CPT code. So just sit with that for a moment. The code that determines insurance coverage still treats these two completely different surgeries as if they are the exact same thing. And that's where this entire problem started. So let's talk about how CPT codes actually get created, because this part is fascinating, but also really, really frustrating. CPT codes are created by the American Medical Association, not by the insurers. To get a new code, you need a major medical society like the ACOG, which is the American College of Obstetricians and Gynecologists, to propose the code. You need research proving that the procedure is unique. You need a lot of data on cost, time, complexity, outcomes of the surgery. You need widespread surgical adoption. You need a multi-year committee review, or reviews, actually plural. And you need approval from the AMA, Medicare, and then also private insurers. It's a huge, huge process. Now, here's the kicker. For decades, no one pushed for excision to have its own code. Why? Because most OBGYNs don't perform true excision. Residency does not teach it. Only a small number of highly trained excision specialists actually do the procedure. Ablation was normalized as standard care for endo. Endometriosis itself was underestimated in how complex and debilitating it truly was. And obviously, women's health was not prioritized, which is not news to anyone. On top of that, insurers heavily financial benefit from the current code. So if, for example, excision had its own code, reimbursement would have to pay much, much higher, because excision is far more complex, it's time consuming, and it's resource intensive. But higher reimbursement means that insurance payers have to pay more, and there's zero incentive for them to push for that. So the system just stayed the same. Ablation and excision remain lumped together. And that's how we ended up with a system that does not recognize excision for what it is. So what does this mean for you and I, for the patients? This is where it really gets frustrating, honestly. Because of the lack of proper coding, excision surgeons are not reimbursed for the true complexity of their work. So what happens then? Many specialists cannot stay in network, so then they're categorized as out of network for anything. Patients face massive, massive out-of-pocket costs, sometimes $10,000, $20,000, sometimes even more than that. And insurance reimbursements are incredibly unpredictable or denied altogether. Patients have to travel across the country for proper care. Patients have to travel to different states for proper care and then recover from a very extensive, intense, invasive surgery away from their home, in a hotel, or in the hospital. Wait lists are incredibly long. And then ablation is still offered as standard care because it's cheaper and easier, even though we are now finding research that ablation can be counteractive to healing, which is a nice word to say. This is also why many excision surgeons work out of network, or they use kind of like a hybrid model, because not because they're greedy, but because the insurance system literally does not reimburse the surgery at a sustainable rate. And I would argue that the majority of these endometriosis surgeons are actually very kind people, and they want to give you the proper care, but they quite literally cannot go through insurance, because then the surgeons themselves and their clinics are having to pay extreme out-of-pocket costs to cover the surgery because your insurance won't cover it. Like, that is just not a sustainable thing, unfortunately. Like, the surgeons also have to get paid. So the people that struggle the most are the people without financial privilege, those without support, those who cannot travel, and those who were already dismissed for years before ever receiving a diagnosis. And it's a heartbreaking example of how inequalities in the healthcare system disproportionately impact women and people with chronic illness, and obviously people that are lower income. This systemic issue exposes something much bigger. The coding issue reveals that endometriosis care is still built on an outdated science and really biases. The fact that excision isn't recognized at its own as its own procedure still to this day reflects gender bias in Medicare, gender bias in medicine, a lack of funding, lack of research, really poor training standards, insurance systems prioritizing cost savings over patient outcomes, fragmented care, what else? Inconsistent diagnostic criteria, and honestly, a historical failure to treat endometriosis as a serious disease, as it is a very serious multi-organ, complex inflammatory disease, and it needs to be recognized as so. The surgical code is not only the surgical code isn't the only problem, though. It's a symptom of a much bigger system failure. And you might wonder, okay, if this is a known issue, why do we not just fix it? Because creating a CPT code is a massive process. To change it, you need a major medical society, like I said before, to submit the proposal. You need data providing that excision is distinct and widely used. You need studies showing cost differences. You need documentation from surgeons across the country. You need years and years of meetings with the AMA, approval for Medicare, and then negotiation with private insurers. Again, we talked about all of this, but it is a huge process and a major undertaking. It's not impossible. It's not impossible, but it is a slow process. And historically, the groups with the most power don't prioritize women's health or endometriosis or excision surgery. But the momentum is slowly changing. I do want to tell you guys that the momentum is slowly changing and it is promising, I hope. While we wait for systemic change, which unfortunately will take years, if not a decade or longer, organizations within the endo community are really stepping it up. And one of them is Endo Excision for All. They're working to increase patient access to skilled excision surgeons, provide literal financial support for people who cannot afford surgery by actually sending them a check and paying for excision surgery, raise awareness about why excision matters, educate the public and the policymakers while also pushing for equitable care, and support patients navigating denials and appeals. They are essentially filling the gap left by the insurance system, and honestly, they're making a real change while we wait for structural fixes. And like I said, the good news is that we are actually seeing some momentum. We have more research, more surgeons advocating, patient organizations pushing for policy change. We've actually started to get some minimal, but some federal attention through bills like the Endometriosis Care Act and more awareness of DIE and the complexity of this disease. And I think most importantly, we have a patient community that refuses to be silent anymore. And that's exactly what we're doing here at the Chronic Chronicles podcast. We are refusing to be in pain silently. The truth is, the system is slow, it's complicated, it's historically stacked against people with endo, but change is possible, and it's already happening because patients, not institutions, demanded it. You and I demand change. And here's how everyday people without medical degrees, political connections, or giant platforms can help accelerate that change. 1, share your story publicly and consistently. Stories are powerful because they expose patterns. When thousands of people share misdiagnoses, delayed procedures, failed ablations, insurance denials, out-of-pocket costs, travel burdens, and emotional and financial impacts, it becomes impossible for policymakers, insurances, and medical societies to ignore that. Here are some ways to tell your story on social media through Instagram posts, TikToks, Reels, written testimonials, public comments on policy proposals, emails to legislators, support groups, and also participating in research studies. Your lived experience is data, and your lived experience is data, and data drives policy change. 2, you can contact your state and federal legislators. So most people don't realize this, but endometriosis policy change happens at both the state and federal levels. You can write or call your representatives and say that we need better insurance coverage for Excision. We need more research funding. We need more medical training. And we need a dedicated CPT code. You don't have to be an expert to contact your legislators. You are a constituent, they work for you. And just a little bonus, legislators love real stories because it gives them material to fight for bills like the Endometriosis Care Act. 3, you can support or volunteer with advocacy or organizations. These groups do a lot of the heavy lifting, but you can volunteer and you can support them. You can support by donating, fundraising, volunteering, sharing their educational content, amplifying their campaigns, and participating in awareness events. These organizations influence policymakers, medical boards, and insurers, and they need community support to keep pushing. 4, you can participate in scientific research and patient registries. One of the biggest barriers to new CPT codes and updated guidelines is data. Every time you fill out a research survey, join a patient registry, participate in some type of study, share surgical outcomes, report insurance denials, or document your symptoms, you are contributing to the data sets that researchers and medical societies use to justify change. Data equals evidence, and evidence equals power. 5, ask your own doctors better questions. You push the system forward every time you ask, is there evidence that ablation is effective long term? Why wasn't excision discussed? What is your approach to deep infiltrating disease? What data outcomes do you track? These questions force providers to reflect on their training and encourage them to pursue continuing education or reconsider outdated practices. Patients drive demand, and demand drives change. 6, you can advocate for excision in workplaces, schools, and local communities. Even small conversations make really big differences. So HR departments can adjust sick leave policies, schools can allow accommodations, local hospitals can be encouraged to host educational events, friends and family gain awareness when you share your experience, community leaders can support awareness days, and employers can sponsor local endometriosis events. Change does not always happen at a national level, and sometimes it starts right where you are in your local community. 7, you can support people who are running for CPT code reform. When the time comes for public comment, petitions, or support letters, patients can participate. Medical societies, legislatures, and the AMA look at public interest, patient burden, advocacy momentum, letters of support, research backing, and testimonies. So quite literally, your voice becomes part of evidence. Number 8, you can donate to or fund local surgical access. So while systemic change is slow, everyday people can make immediate impact by supporting Endo Excision for All, which is financial aid for surgery, local fundraisers for people needing excision, and mutual aid networks. This literally changes somebody's life today while we fight for them long term. Number 9, you can normalize this. Talk about it. Normalize talking about endometriosis. This is not taboo. This is not a period disease. Talk about it. The more we talk about what excision is, why ablation fails, what endometriosis is, why there's no CPT code, why patients have massive bills, and how long these diagnoses take, the harder it becomes for medical societies and insurances to justify inaction. Silence protects the system, and talking dismantles it. You need to speak up. Tell your story. Talk about how this is affecting your life. And number 10, remember, every day people create momentum and institutions respond to it. Almost every major change in disease advocacy happened because patients refused to be quiet. Think about HIV activism, breast cancer funding, fibromyalgia recognition, Lyme disease awareness, diabetes coverage changes. Endometriosis will follow the same trajectory because of us, not because of institutions suddenly caring, but because patients, caregivers, clinicians, creators, and advocates demand better. This system will change because of you and your voice and your experience. Endometriosis excision surgery should not be a luxury. It shouldn't require medical tourism or a GoFundMe. It shouldn't depend on luck, privilege, or the right zip code. The lack of proper insurance code is not a paperwork issue. It's a reflection of decades of medical minimization, gender bias, and systemic flaws. But the more we talk about it, the more we share our stories, and the more that we push for change, the closer we get to a system that finally recognizes the truth. Endometriosis is a real disease. Excision is a real treatment and is the gold standard at this time. And patients deserve access, no matter your socioeconomic status. Thank you for being here, for listening, and for being a part of this conversation. As always, you are not alone. I'm sending you so much love, and I will talk to you next time.